Good morning to all of us, uh, and I am highly thankful to MAPICON organizing committee for providing me this opportunity to bring this scientific topic of fibromyalgia. Fibromyalgia is quite a common occurrence in the OPD, but it is least tested and least diagnosed entity, and usually such type of patient land up in the definition of vague complaints, and they are treated with vague medications, and a targeted approach is definitely needed to diagnose the fibromyalgia. By definition, fibromyalgia is characterized by the chronic widespread musculoskeletal pain and tenderness, which is present all over the body, and fatigue is the second most common feature of the fibromyalgia. There are other overlapping functional symptoms like unrefreshing sleep, cognitive dysfunction, anxiety and depression. As far as epidemiology is concerned, it is present in up to 2% in the general population, but the community-based survey has estimated a prevalence of around 5%. Predominantly affects the females with the ratio of female to male is 9:1, and it is associated with considerable distress at personal level and economic and social burden at societal level. There are certain risk factors that has been attributed for the development of the fibromyalgia. As per the study conducted in related to the fibromyalgia, there are psychological conditions such as somatization, mental disorder, presence of psychological stress, major depression, generalized anxiety, panic disorder, familial major mood disorder. In addition to the psychological aspect of the fibromyalgia, there are certain genetic association, infections, physical trauma and stress. Pathogenesis of the fibromyalgia is poorly understood. In all the studies, they indicate that the pain perception of the fibromyalgia is maladaptive. And the most common maladaptation is increased sensitivity or hyperresponsiveness to the pain, often manifested as allodynia or hyperalgesia. Peripheral sensitization is a reduction in the threshold and increases responsiveness of the peripheral ends of the nociceptors. There is central sensitization that leads to increased neural excitability in the CNS that causes the increased sensory stimulation of the pain. There is also a role of hypothalamic pituitary adrenal axis dysfunction. Clinical features, as we are looking at the picture, the symptom of fibromyalgia is there is widespread pain. Pain all over the body is the common clinical symptom that patient presents with. Fatigue is the second most common. Sleep disturbance is also a hallmark of the diagnosis. Depression is very common. The hypersensitivity, that is allodynia and hyperesthesia to the pain, and there is cognitive loss in the form of memory loss and difficulty in concentration. Clinical feature by discussing all in one by one. Pain is, as I have discussed, that persistent and widespread pain. Patient commonly reports as pain all over the body, typically above and below the waist and both sides of the body, and involve the axial skeleton as well. Pain is poorly localized, difficult to ignore, and severe in intensity, and it is associated with reduced functional capacity. Allodynia and dysesthesia. Complain of body swelling, but there is no objective swelling on the examination. Early morning stiffness is present, but it is not mandatory for the diagnosis. Fatigue is the second most common symptom of the fibromyalgia, present in 80 to 90% of the patient. Patients generally have poor tolerance to the physical activity, including the exercise. Patient complain of completely washed out. Sleep is the most important, one of the most important aspect of the fibromyalgia. Diverse sleep abnormalities and sleep disorders are common in fibromyalgia. It may happen in delayed sleep, repeated awakening in the night, and poor sleep pattern. The sleep is non-restorative, and disturbance of the sleep is associated with further worsening of the pain symptom. It is directly related. More poor is the sleep, more are the symptom of the fibromyalgia. The characteristic polysomnography finding are alpha intrusion in the slow delta sleep. So sometimes it's also called as alpha delta sleep. Increased sleep latency and poor sleep efficiency may also be seen in this subset of the patient. There are certain associated condition or overlapping syndromes. Fibromyalgia overlap with the somatization disorders. As we can see in the diagram, there is poor self-reported state of health, fatigue, disturbed sleep, anxiety and depression, poor emotional function, failure to cope, weakness, morning stiffness, paresthesia, subjective joint swelling, headache, IBS, dysmenorrhea, and poor self-reported physical function. For diagnosis, we have evolved the ACR, American College of Rheumatology 1990 criteria. We have 3 criteria for that. One is ACR 1990. There is chronic widespread pain involving all the 4 quadrants of the body as well as the axial skeleton. In the diagram, we can see there are 18 tender points. Out of these 18 tender points, the presence of 11 tender point on the examination is must for the diagnosis. To diagnose these tender points, a pressure of equivalent to 4 kg per meter square is put. That is sufficient, that is equivalent to the pressure that it can produce the blanching of the fingertips. Original 1990 criteria remain valid and reliable in the experienced hand but still have drawbacks. As in the primary care physician are willing or untrained to look for tender point, hence in the coming criteria, the examination part of the tender point has been eliminated in 2010 and 2016 criteria. As per the ACR 2010 criteria, the widespread pain and for at least 3 months should be there. The other causes of chronic pain should has been excluded. Tender point examination has been replaced by the symptom checklist by the 2 scale, that is widespread pain index and symptom severity scale has been introduced. This has an advantage because the tender point criteria is removed, survey based criteria, and it also can be used to monitor the disease activity. So from the more experienced one, it has been shifted to the general physician. So this is the scale, widespread pain index score. This has a 19 point, 1 in the neck, 2 in bilateral jaw, bilateral sides of the jaw, shoulder girdle, upper arm, lower arm, 1 in the chest, upper back and lower back, 2 in the hip, 1 abdomen, upper leg and lower leg. This is a survey that is conducted on the patient. And on the other side, we have a symptom severity scale, score, that is in the grading of severity of the symptom of fatigue, awakening, unrefreshed, cognitive symptom. 0 is no problem, 1 is slight or mild problem, 2 is moderate, considerable problem, 3 is severe, pervasive or continuous life disturbing problem. For the diagnosis of fibromyalgia, WPI is equivalent to more than equivalent to 7 plus symptom severity score of more than equivalent to 5, that is total of 12, or WPI more than equal to 3 plus symptom severity score more than equal to 9, again 12 should be fulfilled. In ACR 2016 modification, there is no longer exclusion of any diseases required. This emphasized the requirement of persistent and widespread pain for at least 23 months. In the previous ACR 2000 criteria, it was for 3 months, but in this we have a pain persistence for at least 23 months. Widespread pain, that is pain present in at least 4 of 5 quadrants. Diagnosis of fibromyalgia can be made in parallel with any other diagnosis. 2016 criteria has not superseded or invalidated the 2010 criteria. Thus, both criteria should complete each other. So, these criteria are based on the realization that fibromyalgia forms a continuous spectrum from the normal to this very severe and polysymptomatic distress scale. This gives an index of fibromyalgia severity, that is fibromyalgianess. Once we are tackling the patient of chronic pain, we should keep in mind the following differential diagnosis, and it should be ruled out during the course of treatment. Inflammatory cause can be polymyalgia rheumatica, or it can be inflammatory arthritis, that is rheumatoid arthritis or spondyloarthropathy, connective tissue disease like SLE, Sjogren syndrome, infectious component like hepatitis C, HIV, Lyme disease, Epstein-Barr virus infection. Non-inflammatory causes include degenerative joint, spine, disc disease, myofascial pain syndrome, bursitis, tendinitis, repetitive strain injuries. Endocrine dysfunction include hypo and hyperthyroidism, hyperparathyroidism. Neurologic disease like include multiple sclerosis, neuropathic pain syndromes. Psychiatric disease include major depressive disorder, Certain drugs can also produce the symptom of chronic pain, that is statin and aromatase inhibitors. Certain workup before labeling the patient of fibromyalgia, we should exclude the other causes with the help of these investigation. And as per the history, we should go for the routine examination of CBC. To rule out the inflammatory component, we should need acute phase reactant, that is ESR CRP. As per the history indicates, ANA, RA factor or anti-CCP, serum calcium, serum phosphate, alkaline phosphate, thyroid function test to rule out the endocrine causes. Depending upon the clinical presentation, CPK can be done. X-ray and MRE to rule out any of the sacroiliac to rule out ankylosing spondylitis or any other degenerative disease. HIV, hepatitis C and bacterial disease like Lyme disease. Polysomnography to correlate with the sleep pattern. And these days ultrasound is also emerging as to rule out inflammatory arthritis. Now, after we have made a diagnosis of fibromyalgia by excluding all the other inflammatory, endocrine and other psychiatric component, the treatment should be based upon three component: non-pharmacological, pharmacological and other modalities. It is a multidisciplinary approach. For non-pharmacological, patient education is required. Patient should be educated what sort of expectation he or she should have from the treatment, what sort of this chronic pain is going to affect his daily routine activity in the coming life, and to what extent this can be addressed. Exercise and physiotherapy, these play a role. Exercise initially in the patient of fibromyalgia can worsen the pain, but we have to reassure the patient that exercise does not badly damage the joints or other parts of the body, and it should be encouraged so as to rehabilitate the patient in his or her routine daily activities. Cognitive behavior therapy to address as we have seen in the etiology, that major component of the fibromyalgia is the depressive symptom, and hence the quality of life on the basis of depression is also poor. This should also be addressed to counter the depression, anxiety and other sort of the psychological illness. Pharmacological approach is very much centered, and it should be tailored as per the side effect and other profile of the patient. Anticonvulsant has a role. Pregabalin is one of the drugs that can be used. 75 milligrams starting from 1 OD to 1 BD, 75 1 BD, and it can be increased to 150 BD or even 250 BD. Then it should be kept in mind the side effect of the pregabalin. Tricyclic antidepressant amitriptyline has been proven role. It can be started from 25 milligram OD to 50 milligram OD. Again, the major side effect is the dry mouth and other symptom. SNRE in the form of duloxetine has a very proven role. It can be started from 30 milligram and can be taken up to 60 milligram per day. Milnacipran is 25 milligram BD can be used, and it can be increased to 50 milligram BD. 5S3 antagonist tropisterone can be used. Analgesic usually in SAD don't have any role in fibromyalgia. Sometimes they can definitely counter the pain, but for long term it is not advocated because of the side effect profile, and also it is not much beneficial in case of fibromyalgia. Tramadol can be used in certain cases, but again it has a abuse potential. Others, the role of mindful technique. Mindful technique is just to relax the psychological aspect. There is mindful reading, mindful exercise, mindful eating, and certain treatments to just relax and elevate the anxiety and the psychological component. Yoga again working on the same mechanism, and in certain cases acupuncture has been shown to play a role to improve the quality of life. So the take home message is, any patient not fitting into any of the condition causing chronic pain should be evaluated for fibromyalgia rather than labeling a patient as having back complaints. Any such back complaints should not be put on back treatment like multivitamins, antipsychotic, antidepressants. Targeted approach is needed for such set of complaints. Thank you.